Good morning, everyone. We warmly welcome you to the 222nd session of the weekly Sunday webinar series by the Society for Health Research and Innovation. Today, our topic is Human Gait and Assessment, and it's done by Dr. Nalin Andravira. Before moving on to the lecture, let me walk you through some of the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. for you all to join in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the lecture to obtain the certificate for CPD points, and these CPD points are strictly adhered to the NCC guidelines. This is to improve and maintain the standards of the CPD programs conducted by the SHRI. We thank you for your strict adherence and compliance to these rules and regulations. There will be a question time at the end of each webinar. If you have any questions, you can type it in the chat function, and the questions will be answered after the lecture. And if you have any specific questions about your situation, you can email us on office313@gmail.com. Moving on to today's topic, it's Human Gait and Assessment. It's done by Dr. Nalin Andravira. He's a senior consultant physician in physical medicine and rehabilitation at the Modbury Hospital, Adelaide, Australia. Over to you, Dr. Nalin.
Yeah, good morning, ladies and gentlemen, and it's a pleasure to talk to you today, and thank you very much for inviting me, and thank you, Dr. Udari Mahagodage, for being the moderator. And some of the things I talk, you would already know, so I'm just going to highlight a few facts that might help you in the clinical assessment. And I can't emphasize enough the importance of observation or description of gait whenever you have time. Could be a person coming with lower limb pain, recurrent falls, lumbosacral pain, or any focal arthritic type of predominant joint pain, because it will give you some subtleties that can focus, fine-tune your next phase of assessment. So if you look at this slide, starting from the left, the lady with the light blue top, she's walking upright, shoulders are level, there's a good associated arm swing, and she's on the double support phase. If you look at the lower limbs, the front foot heel strike, and the back foot is about to toe off, so double support seems a normal gait. But on the other hand, the young Sri Lankan man has a prosthesis, so his residual stump on the right side will have to drive a mechanical lever arm, and the socket should be well-fitting. The suspension systems should be really great, and there should be good mechanical components, well-functioning of the prosthetic limb for him to walk better. So it's a different criteria when we assess. And on the extreme right top, it will be our elderly parents or relatives who have degenerative arthritis. Kyphoscoliosis happened over a period of time, and they will need a gait aid most of the time to improve their base of support. So the gait aid is a good tool if their risk of falls increase, because by using a static frame, you can increase the base of support by about 4 times, and if the mobility is reasonably faster, you can have a 4-wheeled walker where with brakes you can basically sit on it when you are tired. And if you are reasonably mobile, you can even improve your base of support partially by giving either a single point stick, as in this case, or a 4-point stick, which will further enhance the base of support. And also in the bottom picture, right hand, is a young, fit-looking lady. So she is complaining of in the clinic some pain, anterior right hip and to the anterolateral right hip. And when we got her to do a bit of a one-leg standing time, you can see the contralateral left hip drop. So that's focal pathology of the right hip abductors drop in the contralateral hip. So she will have a more of a inefficient gait, so until you strengthen up and improve the gait to be more efficient and pain-free. And human gait, each person has a unique style, and if you look at the gait, it's always good to start with what you can comment on easily. There's a upright posture or a stoop posture and associated arm movements very easily you can see, and also you can comment on the broad-based or a narrow-based gait, which we expect a narrow-based gait in a kind of a healthy walking person, so that will be very easy to pick up. And also good to emphasize on the alternating movements of different joints when you describe the gait, which we will subsequently. So the gait cycle, as you know, is a rhythmic alternating movement of two limbs, and the stance phase is about 60% of the gait cycle. We'll elaborate further, and the swing phase is about 40%. And there's a double support phase, especially at the heel strike as well as pre-swing, where both feet are on the ground, and it's about 20+%. So if you concentrate on the stance phase of the gait, please look at the diagram from left to the right, and focus on the front foot initially. So the heel strike, the foot flat, and the mid stance, heel off and toe off. But I want you to concentrate is that so this person is upright, has associated arm movements, and we are only seeing the lateral view here. But look at the heel strike. So if the anterior compartment, tibialis anterior, is not eccentrically contracting, he will have a foot flap here. So it eccentrically contracts and controls the forefoot to be nicely onto the foot flat posture. And also the quadriceps muscle on the heel strike phase, eccentric contraction occurs, controlled lengthening occurs. That's what we call eccentric, so that the knee will not go into undue flexion during the foot flat. So you know that when you examine the gait, either from pelvis downwards or from ankle upwards, you can gauge the muscle action, and when you look at it from that aspect, your eyes get trained to assess the gait and identify the muscle contraction, and then come up with a very good idea of different phases of the gait. And I'm going to talk a little bit more about gait rockers, because if you look at any human gait related literature, the rockers come into play. The rockers are, as we saw in the stance phase, from the heel strike, the heel rocker, the mid stance, the ankle rocker, and the toe, the forefoot rocker. So these three rockers are really important, and I'm going to re-emphasize that what happens in the rocker phase is that the body allows the tibia to nicely, smoothly move across the ankle joint, and weight bear, and this is very important in preventing injuries and in having a normal, efficient gait. So again, if you look at it closely enough, and heel strike, remember the action of the anterior compartment, tibialis anterior, in slowing the foot from flapping, the front forefoot from flapping. And also remember in the next ankle rocker, the importance of quadriceps in preventing excessive knee flexion. And also in the forefoot rocker, remember the importance paid by the tibia, gastrocnemius soleus, and the tibialis posterior component in plantar flexing and giving a good push off to move forward. So the rockers are described well in literature. So these are the three rockers that they emphasize when they describe. So in the swing phase of the gait, if we concentrate on the top figure, the black part of the figure, and the black section of that human graphic, the person is on double support. The back leg is about to swing forward, so pre-swing, and then the initial swing, mid swing, and the terminal swing. So if you look at this black part of this graphical picture move, you realize how the muscles come into play. So if you look at the hip from hip and below, the pelvis from below, there's obviously the hip needs to flex, and towards then the knee needs to extend for him to advance his center of gravity. So the importance of hip flexors and the knee extensors will come into play here. And primarily in the case of knee extensors, is primarily driven in this case by the rectus femoris, the anterior thigh part of the quadriceps component. And also you can see towards the terminal swing, the hip is mid swing, the hip will move a bit like a pendulous, and towards the terminal swing, the hamstrings will need to eccentrically contract to prevent excessive hip flexion. So it's primarily driven by the medial hamstrings in this case. So again, the muscles move in a nice sequential fashion to give this fluidy gait for us. And about double support and single support. Double support obviously either at heel strike or pre-swing gives us more stability. But with training, what we are going to do is we are going to increase the frequency of this cycle so that the gait speed becomes better. That is the aim of improving gait speed. Is linked to a lot of health benefits when your gait is reasonably faster for your age and age. And this slide, I really want you to either Google or look at a video and identify what I mentioned. So you can easily pick up some aspects of gait soon as you look the posture, stooped or upright, associated arm movements, and whether there's any waddling of the pelvis when the hip abductors are not functioning, the contralateral hip will drop, so that can be picked up very easily. But when it comes to the musculature, how it operates, the joints to move, it's always good to identify the either from hip pelvis downwards and see the sequence. And sometimes it's important to see start from the rockers and go up. So one of these videos or the picture will show you exactly what we discussed: the importance of the anterior compartment, the importance of the quadriceps at heel strike phase, and then about the taking over during the swing phase of hip flexors, the knee extensors, and the importance of eccentric contraction in the phase of the gait cycle. So I will let you read about it for half an hour and identify this, how this nice rhythmic movement occurs, which will be really good when you assess patients. And apart from this, if you look at the pelvis, there's a pelvic rotation that happens with the swing phase. The swinging side pelvis will move forward, and which will result in a apparent backward motion of the opposite side pelvis. And for you to get a good energy efficient gait, the hip abductors will need to balance this well. Otherwise, you'll end up with a asymmetrical or waddling gait, which is not energy efficient and which can give rise to joint problems down the line. And gait parameters, when you read an article on gait, the biomechanical guys use, biomechanical engineers use different terminology which are a bit alien to we as medically trained people. So when they say temporal, what they mean is that they are describing gait as a component of activity per unit of time. Say for an example, cadence is number of steps per minute. So it will be around 110 to 180 steps per minute in a normal healthy adult. The step time is the time from say from right heel strike to the left heel strike, and the strike time would be from the time from the right heel strike to the next right heel strike. So like that, there's always a timed temporal parameters. Spatial, as you know, is basically length. So it would be the step length, stride length, or your walking base. So the base of support or the walking base is yours, could be your step width, because we have a little bit of a pronation of our feet when we walk, and if it is broad based, you get a wider step width. So that spatial is about the length and the width, and the velocity, as you know, is about walking speed. You can easily measure it with a known distance and a stopwatch. So observational gait analysis, I cannot emphasize enough. So if you have time in your busy clinic schedule, if there's a corridor leading to your clinic room, and make sure the patient is safe, not having a fall in front of you, and ask the person to walk the normal way that he or she walks, with the lower limbs exposed up to at least up to upper thigh level, and look at the posture, and then do a bit of observational gait assessments and identify where the pain is, ask them to point out where the pain is, identify for any kind of focal or point tenderness, and that will give you a lot of additional information for your next assessment and imaging to be requested. And when it comes to kind of a more detailed or objective or calculated mathematical gait analysis, so instrumental analysis will come into place. So it's done in a gait lab. Most of the hospitals here have gait labs where the motion capture is through multiple cameras, frontal, lateral, planar cameras, and some of them are infrared cameras, so that we fix the patient with infrared sensors and make a joint model. So the sensors for the feet would be for lateral malleolus, medial malleolus, on the first base of the fifth metatarsopharyngeal joint on the navicular, and on the tibial tuberosity and lateral knee and the medial knee, and in the pelvis, anterior superior iliac spine, on the sacrum, T12, and the acromioclavicular joint, C7. So like that, you get a model of these markers. So when the patient move the normal gait that he or she would have, these markers get picked up by the infrared cameras, and it derives a computerized model to the screen. So you can see all those joint moving in angles, and you can calculate the angles and identify any subtle asymmetry. And together with that, when on the gait mat, the plates are called force plates. So the moment the person puts weight on it, there'll be a opposite force, which is the ground reaction force, which will be captured. And that way you can identify whether there are any change, especially in anti-G gait, or so whether there are changes in the ground reaction force, the patient is causing the asymmetry. So together with that and the EMG studies, we can create a model and so kind of identify subtleties in gait and discuss as a team to improve or strengthen up or focus on a different area to make it more symmetrical. So this is more in extreme kind of a research related and sort of a very extensive gait analysis parameter, but it is not required in day-to-day clinical practice. But observational gait analysis with a simple gait method or tool would be more than adequate to provide the necessary clinical impetus or the plan for the patient. So the biomechanics of gait in a gait lab environment again uses some terminology. So the kinematics in gait assessment is called joint motion. So you have a model, as you can see on the screen, and how the joints move, pulled by of course forced by the muscles, would be your kinematics, joint motion. So you can get a graph of joint motion. The kinetics is coming from the force plates, which is the ground reaction force when the joint lands on it. So that's your kinetic. And the energy efficiency is calculated by the center of mass. So when we speed up, vertical center of mass increases a bit, and the displacement increases, so that will also be captured. So this is biomechanics of gait in a kind of a nutshell, general description, but important to know these terminology: kinematics, joint angle motion, kinetic, ground reaction force, and center of mass, because when we read articles, these are most of the time used in the description of the methodology or in the results. And on the other side of that is the people who are coming to us with stroke, brain injury, um, multiple sclerosis, spinal cord injury, or following kind of cerebral palsy, which is a perinatal injury, non-progressive neurological injury. So the problem is that, of course, because of the upper motor neuron injury, the muscles are atrophic, they lose mass, and there are a lot of structural changes happening at myofibril level. But together with that, they lack the neuronal higher control. So when training these people to walk, one good tool is to use a body weight harness when indicated, because the body weight assisted harness will take up some of the body weight, and it's easier for the therapy team to get them to do some functional type of activity with the lower limbs. Sometimes they might have to block the knee and advance the ask them to step forward, and that functional training not only will improve the range of motion or the flexibility of the joints, but that will through neuroplasticity, which is an important topic that which is a lot of research done on. Neuroplasticity will allow the higher centers or the cortical control to recruit adjacent fibers next to the injured area to improve the motor control, so that we can improve gait subsequently. So the body weight assisted hoists are pretty reasonably priced, but that will allow the person to weak muscles to hold on the weight partially and do some training, and because their weight is supported. So the pathological gait patterns, you all know it's very boring, so I'm going to rush through that. So we are going to talk about antalgic gait, Trendelenburg gait, hemiplegic gait, few aspects. Parkinsonian gait, I'm going to ask you to think to tell me 8 clinical features of Parkinson's gait when I come to that slide, and the ataxic gait and the equinus gait. So the antalgic gait is primarily so the person has a pain, could be arthritic, so the person spends minimal time on that leg. So relying on the unaffected leg more during the gait cycle. So over a period of time, if this pain issue is not reasonably stabilized, there could be overuse injury on the unaffected side. So that's why it's important to identify the point tenderness and do necessary imaging and go through the WHO analgesic ladder. If necessary, start with simple analgesics and make sure that the weak muscles are strengthened and the range of motion, pain-free range of motion of that particular joint is gradually improved, so that person will become more symmetric in his or her gait. So Trendelenburg gait, as we mentioned, is due to when the hip abductors, abductors are weak, the contralateral hip drops, and if it's bilateral, there'll be a waddling gait, which is very energy efficient and biomechanically abnormal, and can result in wastage of energy during mobilization as well as injuries. So that's why the focus needs to be on strengthening the hip abductors and identifying or treating the cause which probably resulted in that. And the hemiplegic gait, as you know, when humans, we have a stroke, the upper limb, predominantly the flexors get hypertonic. So the shoulder is in adduction, elbow is in flexion, forearm in pronation, wrist in flexion, fingers on the palm, sometimes thumb on the palm. So arm is basically bent, and sometimes it's difficult to passively range. But the lower limb, the opposite happens. The extensor muscles go into hypertonicity or spasticity, so it acts like a stiff strut. And however, the ankle is in plantar flexion and inversion. So in a way, this type of people can circumduct and walk with a stick, so that stiffness of the lower limb extensors help them to where they are, because it acts like a strut, which is evolutionarily very beneficial. However, one of the problems is that because the ankle is in plantar flexion and inversion, they cannot do a heel strike, because they always have a forefoot catch in the ground in the initial contact. So if they have any parapsy mats or anything on the ground, they can trip and fall. So it's good to educate them that good to walk, as discussed with the team, with a stick, even with the circumducting gait, because that's a weight bearing exercise. Keep the flexibility of the muscles, prevent osteoporosis, but make sure the environment is modified that you don't trip. And also, if necessary, if there are some passive ranging of the ankle dorsiflexor is possible, that's always good to have a chat with the orthotist and ask for a ankle foot orthosis, which can be worn inside the shoe so that the ankle can be made neutral. Sometimes when the ankle is really spastic in plantar flexion and inversion, that's when some focal treatment like botulinum toxin of value. But most of the time, we always provide pictures to the family and get them to do some stretching when the person is lying, so that worsening hypertonicity or spasticity can be minimized by ongoing stretching, if you and the team can educate the patient. So Parkinsonism, I asked you a question at the very start. Tell me 8 features of Parkinsonism gait. So it's pretty easy. If you see a person with diagnosed Parkinson's disease or Parkinsonian features coming to you, usually they'll have a bit of a stoop posture. There won't be any arm swing, and they'll have a short stride length, rapid festinating gait, shuffling gait we may call it, and they will freeze at obstacles, and there'll be a little bit of a retropulsion, which primarily causes the falls. There'll be a bit of postural instability, and they will take about 7-8 steps to turn. So those features, you put it together, there'll be more than 8, and those are the classical Parkinson's type of gait. And you also can add a bit of bradykinesia in initiating movement and repetitive movements, and also there'll be a unilateral tremor, which is part and parcel of Parkinson's triad. The ataxic gait, sometimes you might find this type of people, a bit of a staggering movement with a wide base, the difficulty in walking straight line, body also might sway. So it's good if they come like that, sort of do a proper cerebral examination. There could be a posterior circulation infarct, incidental in the brain imaging, but a focused examination would help, and a relevant imaging should be requested, because that's good to identify. I mean, sometimes it's sad that if you see them in the community, some of these people we identify as drunkard when they are not drunk. But I understand that due to some unfortunate reason, I visit Sri Lanka twice a year, but lots of the men in the families have got used to excessive drinking, pulling the whole family down with them. So I really don't know why, but just that advice is that if it is kind of a truncal ataxia, always do an examination related, because he may not be drunk, but could be a pathological ataxic gait. So the equinus gait is primarily we see in people, in kids following cerebral palsy, or when they grow into adulthood in adult clinics. So one of the problems is that please know about the gross motor functional classification system of cerebral palsy. So 1 to 3 they tend to be reasonable walkers, 1 to 2 especially, but the 4 to 5 they are fully dependent. So gross motor functional classification 1 to 2, sort of one of the challenges for them to walk would be that they have this extensive equinus ankle, plantar flexion and inversion to extreme degrees. So sometimes during the pediatric stages, the orthopedic surgeons, the pediatric surgeons do tendon lengthening procedures, osteotomies to nullify and get them to weight bear better. And at times there's a lot of adductor, hip adductor spasticity as well. So they do some tenotomies, the surgeons do some tenotomies to prevent the scissoring of gait. And they also have this crouch gait phenomena. So one of the things is that if they are to benefit, assess them well, discuss with the therapists, and sometimes they benefit from again another ankle foot orthosis if it is going to help, and if the ankle is reasonably neutral and some passive ranging is possible, like in the case of the lateral two right pictures, reasonably neutral ankle position when standing. And coming to the next slide is great and prosthetics, where I cannot emphasize enough. There's lots of many Ranaviro who are having amputations, as well as people who have had more traffic accidents or traumatic amputations. So if you get one of these people, if you have time, spend a little bit extra time. They may have come for another course, but ask about the processes and how they are managing with it, because there could be a lot of instances where the socket is not fitting well, or there could be a lot of frictional injuries on the residual stump, and the suspension of the would not be working properly, and there could be some faults in the mechanical thing. So it's good to tell to them that if the socket is not well fitting, suspension system has not working properly, that we have a very unstable gait, and that will induce faults. And also whether based on where the level of amputation is, whether it is transtibial or transfemoral, they spend a lot of energy then us to go from X to Y, and their walking distance will gradually get reduced with time when they get physically unfit. So that's why it's very important for them to keep walking and maintain good posture control and core strength to be able to be functional walkers. So I think if there are any prosthetic issues, as one section I know is that Fendi Need Society in Sri Lanka is, current president is absolute gentleman, Professor Ajit Malasekara from Department of Anatomy, University of Colombo. Just get in touch with them, say that I've seen this person with this prosthetic issue, whether there's any way that he or she could be assessed if there's no local prosthetists available in your hospital. So always try to help them out, and also remember if the Defence Force people come, they have given their life and limbs to us. So make sure you spend some extra time. And this slide I'm going to focus on the energy consumption when working with the prosthesis. So these two people have osteo integration type of prosthesis, which is quite advanced. But however advanced and however technically high level the prosthesis is, when they walk, they have to use a residual stump to move a mechanical lever. So they've spent more energy. For an example, if it is a traumatic transtibial, in other terms below knee, they spend about 40% more energy. And if it is transfemoral, which is above knee, they use about 60 to 70%. So you can see that for them to walk the same distance that we walk, they are spending very high amounts of energy. So that's why it's very important for them to be fit to be functional walkers. So you might have heard that especially the Defence Force people on prosthesis have gone and won medals, and they are extremely functional workers in difficult terrain. So that's really encouraging. So they should be actually role models for come and speak to the other people with amputations, especially young people for in road traffic accidents. Say that okay, this is how I'm doing. These are my challenges. I overcame those, and so that's very important to encourage. And advancement in gait technology, sort of things have advanced very rapidly over the past 15 to 20 years. There are inertial measurement units now with wearable sensors. So you wear a few sensors in your leg, around your shins, above your thigh area, which will measure all the parameters and can send it via telemetry or Wi-Fi to a device. They are moving in the community, and the team will get a graph of how they have been moving, which muscle is getting fatigued, and in the future the artificial intelligence can capture them and give us a plan. Okay, this is what is lagging, and sort of a plan of how when to intervene, kind of thing. And also it will give us also parameters of how far the person has walked, the gait speed, and symmetry and joint angles and everything. So the wearable devices are going to be very important ongoing measurement tool for people with gait issues. So gait outcome assessment, as you know, for all of us, when we are to undertake something, we get an assessment first, and if we are given a feedback at the end, it's very good positive reinforcement. So when you see patients, if they come up with falls or slower gait, refer them to assess them very well, identify their problem, treat the pain, refer them to therapy program, and get them back in about 3 months time. And if you can do a very 4-meter gait speed test or something like that and reassess them down the line, that will be a very good positive reinforcement to say that, hey, you have done a lot of work, but see, your speed has improved, you have less number of falls, you're more confident. That will be very important. And one important test is to call the timed up and go test, which is on literature has level 1 evidence to be a good predictive tool for in geriatrics. So that we get the person to stand up without using the armrest of the chair, walk 3 meters and come back and sit. So from the time the person stands up without the armrest, the help of the armrest of the chair, and 3 meters and back, that time is called the timed up and go test. And if it improves, that's to show that it has a less chance of falling, or it's a positive improvement. And also the gait speed. Some clinics in North America, they have a 4-meter walk pathway, so that we use the 4-meter gait speed. So stopwatch on at the start, and patient walks the normal speed that she or she would walk at home using whatever the gait aid they use, and go for that 4 meters, and then the 4 meters you click the time out and check the speed, and when at the next visit you reassess it after a program. So that's a good positive feedback, and that way the people tend to be more comfortable. And I can't emphasize this enough. So individual assessment and patient-centered goals are very important. Sometimes we all do that mistake. We are all medically trained, pretty fixated on the medical model. But always ask the patient, what do you want to do? So we may want a full range of motion to improve, but the person might just want to put the arm in the shirt sleeve, or sort of a grasp his cup to drink his cup of tea or something like that. So always get the patient-centered goal and try to work for that, and if possible book another appointment to see how he or she has improved. And I'm again putting the picture. There's thousands of soldiers who have lost their limbs, absolutely fit young men who have served, and so go a bit of extra mile. And for the other one is that these young children, when they have limb issues, could be congenital or traumatic issues from road traffic accidents, it's very difficult to plan things out because they have not achieved the full linear growth. So you might have to discuss with a very senior prosthetist, like in the Friendly Needs Society, or link them up so that there are some techniques which we can use. It's not a prosthesis as such, but allows them during their walking stages to weight bear and walk. And when they have finished the linear growth, of course, they can be sort of go into the proper prosthetic pathway. And saying that, there are lots of other financial constraints, unfortunately, but the Friendly Needs Society is a voluntary non-profit organization, and sort of if you have anybody, I can't I'm very much impressed by what they do, and although I'm not directly involved, but that is some area that you can refer. So summary of gait analysis is there is a dynamic multifactorial process, and as you can see, if you want, you can get a lot of information from simple gait tools, observational gait assessment. But if you want advanced assessment, we have discussed how to assess the kinematics, and the temporal, spatial type of one, and you can get a graph of how all the joints move, as you can see on the bottom graph. Then you can compare the right hip versus the left hip, and you see the asymmetry, very objective mathematical models. So you can work out in more of a kind of research-oriented background, or in elite athletes. So that is always there. But in the clinical setup, observational gait analysis. A simple gait assessment tool would be of much use because of the number of patients that you all see. And the practice points in the elderly population, it's very challenging because they have other comorbidities, excessively fatigued, and could be having some Parkinsonian features, and of course lack the motivation due to multiple issues. And cognitive decline will make them more have lack of insight, less awareness of hazards, resulting in multiple falls, fracture neck of the femurs happening. And so that's few things. So the kids, the children and the family needs to be educated on, this is the kind of the safe way to mobilize inside the house, a flat level ground and things like that. So always try to educate the family and keep the person moving safely as long as possible. So in the rehabilitation strategies, you'll be surprised how many articles are there on compliance. So whatever good work you do will get lost if the person is not compliant. And sometimes when you go to places like Ragama Puneruthapan Hospital or Digana Puneruthapan Hospital, they have done a lot of work, but after some time, patient goes away to do some other treatment, which is, if it helps, that's not bad. But the thing is that the bed is blocked. Bed is kept for that person, but I think it is not fair because it has to be if he wants to go and try another one for several weeks, that bed should be taken by some other person who deserves that. So there are a lot of kind of a practical issues that are there, but one good thing is to, if you can have a bit of a family meeting and explain, okay, you have been here with us for 3 weeks now, so this is how you came, and this is as a team what we have done. And based on this type of a stroke or the brain injury, this is what we are predicting. And, probably show them the scan, take about half an hour for a meeting and say that, okay, based on our expertise and experience, this is what the potential achievable goal is. That might change the perspective a little bit, that half an hour meeting. So just a suggestion. And the modification of the environment is very important. So it could be a wheelchair accessibility or preventing any items on the ground that might induce falls. Put some non-slip mats. You get the family to install a grab rail. Would be of value in patients when they are mobilizing. And education of the family is very important So I'm emphasizing back on the patient-centered goals. And sometimes in the elderly population, their goals are pretty limited because of frailty. It could be bed mobility, doing a sit to stand, and just to make sure that they can go to the toilet and things like that would be the goals. And it's not a bad idea after the patient's permission to get a gait video if you can, with a hospital issued mobile or some kind of a device, so that that will give you lots of objective information when the patient comes next time. So the videos are pretty much commonly used as a good feedback tool. And the functional mobility training, some of these people, when they come with multiple falls, I'm talking about the geriatrics population now, we cannot train them directly with gait training and vertical training. So we get them to do strengthening exercises, wearing ankle weights, simple seated exercises, keeping the body upright, the ergonomics right. And they pass different things, grab different things in front of them while seated. That's a bit of a functional reach improvement. And once they get a reasonable strength, then we tend to get them to be vertical and do mobility training. So that's a plan. And this one, I thought it's important that we emphasize and tell that to our therapy teams, if you're working with a multidisciplinary team, that if you're cognitively intact, although you're physically disabled, if I may use that word, you can use your premotor cortex and encourage the patient to take a big step. So your concentration will drive the motor effect better. So sometimes they use points on the ground, dots on the ground, or musical beat like tuck, 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 to get them to concentrate on it and step according to that to improve the speed and the stride length during training. So you're basically using your premotor cortex to do big, do better. So they will need to concentrate, but the results have been pretty good. So few references and talk now. And I happened to work in Anuradhapura for a long time and met some wonderful people. They tend to be my heroes up to now.
We have come to the conclusion of our session today. If you have any specific questions, you can email us to office313@gmail.com and the questions will be answered via email or stay tuned with the WhatsApp group. I sincerely thank Dr. Nalinda Andravira, Senior Consultant Physician in Physical Medicine and Rehabilitation, Modbury Hospital, Adelaide, Australia, for your time and imparting this knowledge on us. And I thank you all for participating in this lecture. Well, I welcome you all to again join with us next Sunday for another session. Please fill the post-assessment form so that you can get the CPD certificate for this session. Thank you very much.